from King Abdullah Medical City, Riyadh. And myself and Abdullah Hadib and Dr. Abdurrahman Ruwaili will be moderating the sessions. We'd like to welcome Dr. Ahmed if he's with us.
مرحبا مرحبا شكرا على هذه الفرصة, and thank you very much for the opportunity to contribute in such a wonderful activities, and hopefully it will be very informative and productive. Thank you.
Thank you, Dr. Ahmed, and we'd like to remind everyone that we'd like to make our activity as interactive as possible, and anyone with any brilliant opinions, discussions, comments, or even questions, all questions are important. You can ask, and we'd like to make it as interactive as possible. And of course, with help of Dr. Ahmed, this will be, inshallah, very beneficial. Dr. Zainab, if you want to share your slides.
Yeah, sure. Is it clear?
Yes, it's clear.
Okay.
Is there an issue with the sound? Because I cannot hear anything.
Do you want us to start now or 1:05?
Okay, okay.
Yeah, I'll just give 2 minutes just to let more residents to join, and we'll start at 1:05. Zainab, you can start.
Okay. Marhaba. So today I'll discuss repair of aortic valve and valve sparing operations. Firstly, the patient who is like a candidate for aortic valve repair are patients with aortic regurgitation and with the normally functioning aortic valve with root or ascending aneurysm dilatation or ascending aneurysm. The TAA is the gold standard to study the valve and the mechanism of the regurg. Each component of the aortic root, the annulus, the sinuses, the sinotubular junction, and the cusp need to be studied carefully with the ascending aorta. The cusps are the most important to be studied. The number of the cusp, the thick the cusps, appearance of the free margins, the journey of the cusp during the cardiac cycle, and the line of coaptation. Even intraoperatively, the cusps are determined for the feasibility of the repair. If the cusp is thin and mobile with a smooth free margin, the repair is feasible and more likely to be successful. If the cusp is calcified, fibrotic, or scarred, these preclude the repair unless a patch used for repair. Khoury classification for aortic regurgitation is important to be familiar with because of the surgical, to determine the surgical operation. There is a three type for aortic regurgitation. The type 1 when the leaflet is have normal motion. Type 2 when there is excessive leaflet motion, and then on the type 3 restrictive leaflet motion, which is least likely to be repaired. In type 1, there's subdivided to 4. Type 1A, which is dilatation of sinotubular junction. Type B, which is dilatation of the sinuses of the valsalva, and then dilatation of the ventriculo aortic junction. It's type C, and the leaflet perforation type D. The technique of repair, when there is a cusp, it's determined what is the reason for, or what is the cause of the aortic valve repair. So if you have cusp perforation, the cusp perforation due to, usually due to either iatrogenic or a sequelae of healed infective endocarditis, or as a result of resection of papillary fibroelastoma. It's repaired by simple patch repair with autologous fresh or glutaraldehyde fixed pericardium. If the hole is like less than 5 millimeter, fresh pericardium can be used to fix this hole. But the patch needs to be bigger than the hole, because it's retracted with the healing. And use of the continuous Prolene suture, the patch can be sutured around the defect on the aortic side. The repair for cusp extension, it's used in case of incompetent valve due to rheumatic or congenital, using a bovine or autologous pericardium. When there is a cusp prolapse, the cusp prolapse is caused by elongation of the free margin, and it can be corrected by plication, like here in the picture, plication of nodule of Arantes. And the degree of plication is depend on examination of the other leaflet and the line of coaptation. When there is a stress fenestration with the dilatation of sinotubular junction, it's increased the stress along the free margin of the cusps, causing the cusp to have fenestration and thinning of it, and it may be detached from the commissure, and it can be repaired by weaving a double layer of 6O Prolene along the free margin, and tie it with the pledged suture on the commissure side. Bicuspid aortic valve, this is the most common aortic repair, the bicuspid with the leaflet prolapse. The most commonly, the anterior leaflet is the one that prolapse. and it's attached to the interventricular septum, and the posterior leaflet would be attached to the fibrous component of LVOT. As long as the posterior cusp is normal, the repair is possible, and the repair of the bicuspid aortic valve by excising the raphe and the free margin of the anterior cusp is shortened by plication of the suture, so that the length of the free margin is similar between the posterior and the anterior cusp and coaptate at the same level, as shown here. So excision of the raphe and then plication. And then you can use do subcommissural annuloplasty, reduction annuloplasty. If there is incompetent bicuspid aortic valve and dilated annulus, aortic valve sparing is more appropriate procedure than just cusp repair. If there is no sinuses aneurysm and the annulus is mildly dilated, then reduction annuloplasty can be done to increase the area of coaptation. The reduction annuloplasty, application of subcommissural triangle using a horizontal mattress for proline with plagiated outside the aorta, as shown in the pictures here. The suture passed from the outside to inside of the aorta through the aortic annulus of both cusps 2 millimeters below the commissure. Then the same suture passed through the annulus and subcommissural triangle 4 to 5 millimeters below the first one and tied within the first one outside the aorta. Aortic valve sparing operation is used to preserve the aortic valve in patients who have aortic root aneurysm or ascending aortic aneurysm with aortic regurgitation. When there is aortic insufficiency due to ascending aortic aneurysm, with the dilatation of sinotubular junction will displace the commissure of the aortic valve outward and will prevent the coaptation. And usually it is asymmetrical. The commissure of the non-coronary cusp are the most commonly affected. If the other components of aortic root are normal, then simple adjustment with ascending it will restore the valve competence. This repair is accomplished by transecting the ascending aorta 5 millimeters above the sinotubular junction and pulling the commissure upward and close to each other until the cusp coapt. The three commissure form an imaginary triangle, and the diameter of the circle that contains this imaginary triangle is the diameter of the graft. And because the triangle is not always equilateral, and the commissure must be spaced according to the length of the free margin of each cusp. So, sizing of the diameter of the circle with transparent valvular sizer. The diachronic graft is sutured at the level of the sinotubular junction with continuous 4O proline. If after adjusting the cusps do not coapt at the same level, one or more cusp elongation or shortening might be needed. The valve competence can be tested by cardioplegia into the graft and observe the LV dilatation. If the non-coronary aortic sinus is dilated, then a new aortic sinus can be created by tailoring the graft with the tongue of tissue, it's like showing here in the picture, that is sutured directly to the aortic annulus. The height of the new aortic sinus's dacron should be 3 to 4 millimeters more than the diameter of the graft. And the width of should be 3 or 4 millimeters more than the estimated intercommissural distance to allow the graft to bulge and create a new aortic sinus. When there's for the aortic root aneurysm, a large proportion of the patient with root aneurysm has normal or minimally stretched aortic cusps, and aortic valve sparing operation is feasible. Two types of aortic valve sparing, remodeling and re-implantation. Remodeling may be inappropriate if the patient has aortic root aneurysm associated with a genetic syndrome and annuloaortic ectasia. Remodeling, which is also called the Yaqub procedure. The ascending aorta is transected and the aortic root is dissected circumferentially down at to the level of the aortic annulus. All three aortic sinuses excise, leaving approximately 4 to 6 millimeter arterial wall attached to the aortic annulus and the coronary orifices. The three commissure are gently pulled vertically and approximated until the cusp coaptate. The three commissure from triangle form a triangle, and the diameter of the circle that contains that triangle is the diameter of the graft that to be used for remodeling. The stentless valve sizer are very useful to determine the diameter of the graft. The space between the commissure are marked in one of the end of the graft, and the graft is tailored to create three aortic sinuses as shown here. The height of these new aortic sinuses should be approximately equal to the diameter of the graft, and the three commissure are suspended in the graft, which is then sutured to the remnant of the aortic wall, close to the aortic annulus with continuous 4-0 proline suture. The coronary artery are re-implanted into their respective new aortic sinuses. And the aortic cusp are inspected to make sure all three are coaptating at the same level. We can assess as previously saying, valve competency by injecting cardioplegia, and then the distal, the graft is then anastomosed to the distal aorta. The re-implantation of aortic root is also called David procedure. The procedure can be performed in all patients with aortic root aneurysm, but it's particularly valuable in a patient with dilated aortic annulus. It's technically more demanding than remodeling. And in the original description, the procedure of this procedure, the aortic valve was re-implanted into a tubular dacron graft, and no new aortic sinuses were created. There is now available graft with sinuses of Valsalva. The operation goes by the three sinuses, the aortic sinuses of are excised, and the horizontal mattress of 2-0 or 3-0 ethibond are passed from inside outside of the to outside the alveoli below the aortic annulus. Horizontal plane from the nadir of left and non-coronary cusp are slightly scalloped between the non-coronary cusp, and slightly scalloped from between the subcommissure triangle of the left and right cusp along the membranous septum. So as shown here, the ethipond suture are passed in the at the annular level. These sutures frequently pass through the right atrial wall in the area of the membranous septum, and the left atrial wall in the area of subcommissural triangle between the left and non-coronary cusp. Then the tubular dacron graft with diameter should be equal to the double the average height of the cusp, -2 to 3 or 3 millimeter, and the three equidistant mark placed in one of its ends. The suture that previously placed in the LVOT are now passed through the graft. If there is obvious dilatation of the aortic annulus, suture should be spaced symmetrically along the muscular interventricular septum, but close to each other at the subcommissural triangle of the non-coronary cusp, because this is the area where dilatation occurs. The suture are then tied on the outside of the graft. Then you cut the graft in a length of approximately 5 centimeters and pulled gently, and the three commissure are also pulled vertically and temporarily secured to the graft with transfixed 4-0 proline suture buttressed on a small Teflon felt plaget, but these sutures are not tied. Once all the commissure are suspended inside the graft and the commissure and the cusp inspected and they are all correctly aligned, suture are then tied on the outside of the graft. Then you do a running suture right at the level of the annulus and remnant arterial wall, and it should be watertight. And started at the level of commissure and stop at the nadir of aortic annulus where the suture are tied together. The coronary artery are re-implanted into their respective sinuses, and the coaptation of aortic cusp is inspected, and if there is a prolapse, to be corrected if necessary. It is important that the coaptation level is well above the aortic annulus, and to make the aortic cusp to move a bit more centrally and increase their mobility, creation of new aortic sinuses are done by application of the graft at the level of sinotubular junction and between the two commissure. The valve competence assessed by cardioplegia and the distal anastomosis to be performed. The outcome of isolated aortic valve repair, in general, it has a better durability of aortic valve repair in type 1 and type 2 aortic regurgitation compared with the type 3. If the aortic regurg is caused by prolapse, the published outcome is 95% freedom from re-intervention during the first 5 years. For the bicuspid aortic repair, the risk of re-intervention during the first 10 years following the bicuspid is reported to be 5 to 22%. The published result of bicuspid valve repair tend to be slightly worse as compared to the tricuspid aortic valve repairs. The result of valve sparing root repair, the remodeling technique has better reservation of aortic root dynamic and physiological cusp motion than re-implantation technique, but effectively the new sinuses created during the remodeling allow the root to expand through the interleaflet triangles, while re-implantation constrained the root structure within the tube graft, which lead to the risk of the cusp that the cusp could be damaging by touching the graft during systole. And there is a several authors reported that dilated annulus, if it's more than 25 to 28 millimeter, there is a risk. It is a risk factor for recurrence of AR after remodeling, which was not the case with the re-implantation technique that is included in an annuloplasty through the proximal suture of the tube. The long-term data accumulated for valve sparing root remodeling technique have shown that in an experienced center, freedom from reoperation can reach to 96% for almost 20 years with the re-implantation technique. A meta-analysis published by Arab Khani in 2015 included a total of 4,777 patients from 31 largest published paper between 2000 and 2014. Both type of valve sparing, the remodeling and re-implantation were studied. There was no clinical advantage in terms of survival and reoperation of one technique over the other was founded, and the hospital mortality was low as 2%. And the risk of re-intervention is 1.3 per patient per year. Thank you. Any question?
Excellent. May I start the discussion? It's an excellent presentation and very well informed, very well prepared, and I very much enjoyed it. Summarize really the pathology and the outcome in a very methodologic way. I will ask you a question here. Would you do valve sparing operation in a patient with Marfan syndrome?
You mean which type of valve sparing you would use? If the
well, it doesn't matter which type, but I think if you have a patient who have annular ectasia and severe aortic incompetence due to Marfan pathology, what is from your reading, what they say about using valve sparing operation, whether David or Jakob, in this kind of patients?
Actually, I didn't read about Marfan in specific, but for the annulo-aortic ectasia, I found that using a remodeling technique is better than if the cusps of aortic valve is healthy tissue, and the cause of aortic regurgitation is mainly the dilatation of the aortic aneurysm.
Okay, I think I can give you my insight on that. I think from my experience and from my readings that valve sparing in this particular group of patients is not very advisable for the following reasons. One, the annulus dilatation is almost always in this group of patients is very dilated, and the pathology of the Marfan also due to the dilated sinuses. And when the dilated sinuses would lead to expansion of the commissure and dysfunction of the coaptation. The second point is that there is a pathology of elastin fibers in the leaflet itself. So therefore, it is not advisable that the longevity of the repair is not as per the experienced surgeons, and trials and publication doesn't last for long, any of these repairs. I leave the podium for,
So Doctor, you mean?
Yeah, go ahead.
I wouldn't do any form of repair for a patient who come to me with Marfan and dilated and severe AI.
So you mean the Marfan syndrome is like the tissue is even if it's look
even if it looks normal, it is not normal.
Healthy or normal. Okay.
Yeah.
I mean, Dr. Ahmed, David, it will fix the. You mean the part of the annular dilatation? Probably it will prevent that, but not the other issue with the leaflet pathology itself.
Exactly.
Even like how long usually would David they last? Actually, I'm not aware. Like such population with normal leaflet, like 10 years or something, that they will usually have a recurrent pathology with AR.
You mean Marfan?
Yes, Marfan after
yes,
David.
Yeah. I think I personally operated at least in the last 15 years on since I came here, because my colleague, he used to use this David because he's a Canadian trainee. I'm a UK trainee, so I use Jakob, and we have seen recurrence in usually when they come around 9 years, 10 years of time with a very severe AI. And at the same time, you will find that the leaflets are very badly damaged. Sometimes you even think they might have endocarditis, but actually the leaflet is damaged because of the Marfan pathology itself. And the reoperation in these patients is very, very risky.
Mm-hmm. So in what population, Dr. Ahmed, you use in what specific population you would see that the better results on the long term in terms of valve sparing procedures in your practice?
I think, and I have a view personally on the valve procedures, particularly valve sparing procedures. Patient selection is very important, and surgeon experience is very important. Why I say that? I think if you are doing a valve sparing operation once or twice a year, it's better not to do it, because your chances of failing in these particular patients is very high. It needs high volume centers. It needs subspecialization. And at the same time, you create a kind of a program for that particular pathology. It is an excellent operation in the right patients, young patients who have, in terms of anatomy, which our colleague here described it very well in terms of patient anatomical selection. But my view is that you really need to have a high volume to achieve. It requires practice in order to achieve, and the learning curve, in particular this kind of patients, is not very short. It requires, and that's the reason I say you need a good volume. And these kind of patients are not very common. You will not see every month you have a young patient who have severe AI and normal annulus and only pathological leaflets. So therefore, it's not really very common pathology we see, particularly in Saudi Arabia. I'm not sure about the other centers.
Oh, thank you, Dr. Ahmed. What about in cases of the dissection and with involvement of the root? Probably it's a different topic, but in case of like, would you use any valve?
Does anybody have other questions?
Yeah.
Or comments? Hello?
Hello, yes, Dr. Ahmed, can you hear me? Hello? Probably.
Probably he has a problem, Abdullah. We can't hear.
Okay.
Hello?
Dr. Ahmed, can you hear us?
Yeah, now I can hear you now, yeah.
Sorry. Yeah, so Dr. I was just asking in terms of in case of dissection and involvement of the root in case of dissection, and what kind of usually techniques you would use. Probably it's another topic, but I was just wondering.
I think aortic dissection is a very good pathology for aortic valve preservation. Because especially for patients who presented early and there isn't severe damage to the aortic valve itself, and the leaflet itself looks healthy, and it's just leaking because the commissure has been stretched, and at the same time becomes flabby because of the losing of the support of the adventitia and so forth. And I think almost always you could preserve the aortic valve in aortic dissection, and you do just Dacron graft and re-implantation of coronaries. And the three commissure, you suspend them with 3 pledged stitches to the Dacron graft. And they almost always you could achieve very good coaptation. And like what our colleague have said, you just test the valve with some saline in the beginning, but make sure this valve is competent. And also you could stress the valve also by cardioplegia to make sure that it sustains some pressure and so forth. So in aortic dissection, patients who presented early, you almost always be able to preserve the valve.
Thank you, Doctor. Any other comments, questions, or additions? Zainab, would you like to add any other comment or question, or shall we move to the next?
I guess so.
Excuse me,
عليكم السلام ورحمة الله.
I just want to ask about the dissection around the roots. How much we go deep around the roots, Dr. Ahmed, the implantation of the diaphragm graft? We have to go deep or just few millimeters? You hear me?
أحمد يمكن صوتك بعيد. يمكن دكتور أحمد did not hear you. Maybe if you can come closer to the phone.
Okay, wait just a minute. الحين يا عبد الله كويس؟
ممتاز الصوت.
طيب كنت أسأل عن ال dissection around the aortic root. How much we have to go beyond the root for the diaphragm to diaphragm graft to implant?
You mean in valve preservation, or you mean in aortic dissection?
Ahmed, you mean in valve sparing in aortic dissection situation? Doctor is asking.
Okay, I tell you regarding the annulus. The annulus is of the aortic valve is very complicated structure, and it's connected to left atrium, and at the same time it is related to a conduction system and also related to the septum and so forth. So the landmark of the annulus is always very clear. And the three landmark for particular valve preservation is the interleaflet trigones. You shouldn't pass beyond that trigones, because if you read, for example, the papers, which is a landmark paper for valve preservation of Jacob regarding the function of the trigones. Because if you preserve an aortic valve, the trigone must be preserved in order to adapt and the pressure for the of the LV to help the leaflet to co-opt better. In terms of dissection, I think you also don't go beyond the fibrous structure of the annulus, because if you, by any chance, you try to cut, for example, toward the left coronary cusp, you end up in the left atrium. If you cut a little bit more than what you should in the right coronary cusp, you end up in the very likely with a VSD. So it is a very unique landmark, fibrotic, and you shouldn't go beyond that. Does that answer your question?
Yes, thank you, doctor. That's fair enough. Thank you.
Okay, thank you, everyone. We'll start our, inshallah, next talk in at 1:50 minutes. We will re-meet at the same link. Just 10 minutes.
Okay.
Break. Thank you.
Okay, thank you.
Khalifa, if you would like to share your slides. Okay, Khalifa, you can start now, please.
Good afternoon, everybody. Today I will speak about minimal invasive aortic valve surgery and TAVI. And I'd like to thank Dr. Ahmed. I think he is not there still, but for joining us today and accepting the invitation. As an introduction for minimally invasive, in general, the aortic valve surgery started by implanting the Havergal valve in the descending aorta in 1956. And since that time, the evolution started and culminated with establishment, lastly, with the TAVI technique. So that make a cardiac surgeon a new challenge. He should do an efficacy and safely and good outcome with conventional aortic valve replacement, and also he should provide this minimal invasive procedures. First, as an essential for minimal access for aortic surgery, should be cosmetically superior incision, and also reduced post-operative pain and faster recovery with improved post-operative respiratory function, as the integrity of the sternum is still there, and also it should be performed with the same degree of ease and speed as conventional, with no more mortalities or extra mortalities, and also provide an access to only heart and relevant structure around it, and we are not dissecting the area which we don't need. And lastly, facilitate re-operation later on. Principle of minimal access. It should be ability to apply stable aortic cross clamp and to visualize aortic valve completely and implant the valve safely, and also to achieve the same degree of myocardial protection, and also ability to deal with the issues of aortic root and ascending aorta with the ease, and ability to quickly convert to standard sternotomy. The safety and reproducibility of this access is depend on availability of cardiac anesthesia, and also TEE with the placement of pulmonary artery catheter, and with the pacing wire capability, and also placing percutaneous arterial and venous cardiopulmonary bypass. So sometimes you need it, and also ability to use vacuum assisted venous drainage during cardiopulmonary bypass, and minimal access retractor should be available, and other instrument for minimal invasive should be available, and ability to monitor myocardial protection by TE, and surgeon himself, he should be expert in conventional and minimal access. First, we'll speak about approaches. We have 4 approaches: upper hemisternotomy, and right parasternal approach, and right anterior thoracotomy, and transverse sternotomy. I will speak about only upper hemisternotomy and right anterior thoracotomy. The other 2, one of them it's just abandoned, and the other one it's just peel out. For the upper hemisternotomy approach, this is the most popular of all minimal access approach for aortic valve. You can see the incision in the skin. It's very minimal, which giving 6 to 8 centimeter vertical midline incision in the upper part of the sternum, just above the mammalian angle, up to the level of the third or fifth, third or fourth intercostal space, and at that area you can go to mark a T through the fourth intercostal space, or just J-shape mini sternotomy. And at this area, while you are opening the sternum, you should give care for lima. Failure to adhere to this principle it will develop lateral fracture of the sternum, resulting in 3 fragments of the sternum, or continuous lower extension of midline fracture going down, and this will retract and slowly going intraoperative and postoperative bleeding, and this also very difficult to close. There is no need for prophylactic dividing the right or left internal memory artery, and we should use a small blade retractor, which is called cross Baxter retractor, and the pericardium should be opened in T-shape inferiorly in the midline, and at least we will use 3 pericardial suture applied to just pull out and bring the aorta anteriorly. Then we will do epi-aortic ultrasound to exclude the atherosclerotic area, and then we'll do systemic hydrogenization and ascending aortic cannulation with the standard fashion, and the right atrial venous cannulation induced directly through the appendage. Or if you are going for percutaneous, you can go for femoral vein, and the cannula should be at the border of the superior vena cava in the right atrium. Pulmonary bypass, we should core cooling up to 34 to 35 degrees and use vacuum assisted venous drainage. So, sometimes if the aorta has regurgitation, we will use retrograde cardioplegia catheter, which we should bend it before inserted, and with T guided placement. Then trans-aortic left ventricle vent, we can use through the right superior vein or left atrial dome venting directly. Then operation proceed as usual. The aortic cross clamp applied. After that, we'll go for cold blood antegrade cardioplegia with T monitoring for left ventricle distension. And retrograde, we can add those can be administered. Then standard aortic valve replacement will be going on with oblique aortotomy, going to the non-coronary cusp, and suspend the commissure and inspect the valve, then incise the valve and replace it with the appropriate valve. Then we will close the aortotomy, and to make sure to apply or connecting the basing wire and inserting the chest tube while you are on bypass, because and even de-airing before that, because this will limit the injury of the heart, and while the heart is collapsed. De-airing needle is placed in the ascending aorta before removing aortic cross clamp. Then after that, the heart usually recover with the sinus rhythm. If so, recovery in ventricular fibrillation, we will need for a defibrillator. That's why it should be pre-op applying the external pad, or sometimes you can use the pediatric internal pad. Then de-airing it should be used by TE guidance with combination of ventricular filling till you will be sure the ventricle is filled. Otherwise, the air will be trapped there with stable positioning and external compression you can apply. And you have to remember that the successful and complete de-airing does not occur until the blood has begun to circulate in the pulmonary and systemic circulation and the heart starts to be ejected. And before you are going off bypass, as I mentioned before, pacing wire and chest tube should be there, and wire should be out of the inferior mammary, inframammary area in the intercostal, fifth or sixth intercostal space. And for the chest tube drain should be a subxiphoid approach, and you will tunnel it, subxiphoid approach, and you will tunnel it with long retractor through the pericardium with tactile sensation and feeling, so you will not injure the heart. Then after that, wean from cardiopulmonary bypass, then perform standard fashion for decannulation and peritoneum. Then after that, hemostasis, you will do a hemostasis, especially in retrograde catheter, because it will be retracted and down, and also the draining tube entry point, you should check it, and left ventricle and the lower edge of the sternum at the T areas, and the sternum closed using after that using 3 or 4 horizontal, as you can see here, horizontal sternal wire and oblique wire to place between the lower intact segment with the sternum of T of segment. The outcome for this approach, they are mentioning it's originally have been done in Cleveland Clinic in Prof and his colleague, and after that also Birmingham and Women's Hospital, they did their series, and they mentioning the reporting lower level of morbidity and mortality and equal to conventional technique. For the right anterior thoracotomy, this is minimal access primary aortic valve replacement in adult. If you can see here in the second intercostal space, just lateral to the sternum edge, and would be for male mainly, and female will be crossing the breast tissues, and the right side of the aorta will be visualized in such incision. Then the aortic and venous cannulation will be done, and better to be done peripherally if you could. Then especially clamp may be required to reach the aorta. It's not the usual clamp which is used in conventional surgery. Exposure via this incision could be optimized. Sometimes you cannot see the aorta, or while you are dissecting, you cannot expose the aortic valve efficiently. You can extend the incision and go through sternum and transverse sternotomy. They call it transverse sternotomy, which is 8 to 10 centimeter transverse incision, and at the mandibulo-sternal angle, and extend to the other side with the. But in this approach, internal memory pedicle, so it has to be ligated and divided to get adequate exposure of aorta if you couldn't proceed with the right anterior thoracotomy. For the outcome for this approach, the Gleber is reporting 138 patients compared out with the conventional one with the propensity matching group, showing associated with lower incidence of blood transfusion and post-operative arterial fibrillation and shorter mechanical ventilation and hospital stay with comparable perioperative morbidity. And in other group, Gelmanov demonstrate valve, minimal invasive aortic valve with the right anterior thoracotomy safely performed with acceptable mortality and morbidity, with shorter hospital stay and no difference in perioperative complications. For the other two approaches, right parasternal approach, this is abandoned because it's required second operation, and they are reporting incidental of lung herniation. So no one will do it. And the other one is for reoperation of minimal access aortic valve surgery, especially in subgroup patient where they have been done CABG before and they are come back for aortic valve, and they are, as they mentioned, elderly and sick and many comorbidity. We are in the era of TAVI, so those patients will go for TAVI most likely because the mortality risk will be 8 to 12%. Then we will go for percutaneous treatment, percutaneous aortic valve replacement or intervention. As a history, the work of percutaneous treatment of aortic valve disease done in Danish researcher called Andersen in 1980s, and he experimented in animal lab with the balloon expandable stented valve. Then this technology was acquired by PPT company, then further developed, then sold to Edward, and they worked on with the surgeon called Alan Kriber. Then subsequently, the valve was adopted in US with further modification, and the initial approach by Kriber was to insert the valve via femoral vein, then snake the catheter through mitral valve, then to the aortic annulus, and sometimes even use transseptal puncture. These approaches are tamed down now because difficult and with difficult procedure with high mortality and 8% stroke rate. An animal experience were carried out at the same time by Michael Mack and Todd Dewey with Lars Svensson using trans-apical approach. Subsequently, they introduced the retrograde Trans-Femoral artery approach, which we are in this era now. As an indication or as a guideline by the European Society for Managing the Aortic Stenosis and the TAVI choice, here the SAVR is recommended in younger patients who are low risk for surgery, less than 75%. Low risk, that's mean Euroscore less than 4. And who are operable and unsuitable for transfemoral TAVI. TAVI is this is class 1 recommendation with level of evidence B. TAVI is recommended in older patients with equal or more than 75 years in those who have high risk with Euroscore more than 8. Or unsuitable for surgery. This is class 1 recommendation with level of evidence A. SAVR or TAVI are recommended for remaining patient according to individual and clinical, anatomical, and procedure characteristic. This is class 1. And non-transfemoral TAVI may be considered in patient who is inoperable. This is class 2B. and balloon aortovalvotomy may be considered in hemodynamic unstable patient, maybe bridging for SAVR or TAVI. And this is just the diagram explaining the path of aortic stenotic patient from European Society at last with the American guideline for SAVR versus TAVI in patient whom appropriate for diagnosis for symptomatic and asymptomatic patient with severe AS and any indication for ABR and his age less than 65 or have life expectancy more than 20. SAVR is recommended class 1, and for symptomatic patient with severe AS 65 to 80 have no anatomical contraindication for TAVI. Either SAVR or TAVI is recommended after a shared decision in the heart team. For symptomatic patient with severe AS more than 80 or for younger patient and life expectancy less than 10, no anatomical contraindication for TAVI. Trans-Femoral TAVI is preferred over the SAVR class 1 indication. In asymptomatic patient with severe AS with ejection fraction less than 50 and less than 80 or equal 80 and have no anatomical contraindication for TAVI, TAVI and SAVR should follow the same recommendation. This is class 1, and for asymptomatic patient with severe AS and abnormal exercise test and very severe AS, rapid progressive with elevated BNP, SAVR is recommended over TAVI. And for patient with indication for ABR, for whom bioprosthesis valve is preferred, but valve or vascular anatomy not suitable, for TAVI, SAVR is recommended. All of them class 1 indication. For symptomatic patient with severe AS and high prohibitive risk, TAVI is recommended. This is class 1, and for symptomatic patient with severe AS and whom predicted post-TAVI or post-SAVR survival less than 1 year, whom minimal improvement in quality of life and palliative care is recommended after shared decision making. This is class 1, and the last one, in critical patient with severe AS, percutaneous aortic balloon dilatation may be considered for bridging to SAVR or TAVI. This is class 2B. This is the diagram showing the management plan for the TAVI or SAVR in AS. For device for TAVI, there are two types of valve currently approved by US FDA and marked approval for commercial sale in Europe. The first one is core valve revolving system, and the second one Edward Sabine system, Edward Life Science Corporation. This is the Edward valve with different generation, Sabine and Sabine XT and Sabine 3. With this is the self core valve, and the next generation evolved R, and the new generation is evolved Pro Plus. We'll take one by one separately. Edward valve, it's a balloon expandable tri-leaflet equine pericardial valve, and attached to the steel framework, and the available size can go with 20 to 23 and 26 and 29, 4 sizes, and can be deployed through transfemoral, apical, transaxillary, transcarotid, transapical, and transaortic approach. For core valve reporting system, it's self-expandable methanol frame that contain tri-leaflet with porcine pericardial tissue prosthesis. Deployed in retrograde fashion, go through the femoral artery, through the transfemoral, transaxillary, or transcarotid, or even transaortic approach. Available size 23, 26, 29, and 31. Then this is the device comparison between the two valve, the choice trial, which show 30-day device success rate was 95 in balloon expandable and 77% in self-expandable with significant p-value. And the superiority of balloon expandable valve was attributed to significant lower incidence of aortic regurgitation. And the mortality figures were comparable at both 30 days and 1 year follow-up, with similar stroke and death at 1 year. Incidence of new pacemaker implantation and aortic regurgitation with valve migration, it's more higher in self-expanded. For the risk score for operative mortality, there are two risk scores have been suggested to aid the heart team in decision making for surgery in general. There is a Euro score and STS score. Both score define the operative mortality within 30 days from from operation and later on. And there is some scoring system which they are specifically for TAVI, which called the observant score and the SIR-TAVI score. This is the pre-procedural evaluation for TAVI. We should do CT pre-TAVI for aortic valve, core valve, and also evaluating the iliofemoral axis for detailed anatomy and size of aortic valve annulus and the size of aortic root. And we can go also for left and right heart cath to evaluate for artery disease and pulmonary hypertension. Procedural succeed after TAVI. Early experience, the early experience when TAVI was associated with the procedural was 70 to 80%, and recently the STS and the trans-catheter valve therapy registry investigate have been reported to 92. The surgical aortic valve replacement versus trans-catheter aortic valve implantation. We have an early experience after the first TAVI in 2020 by Kleber and his colleague. Procedure succeed was 80 in both devices. And for randomized clinical trial, we were came across 8 clinical trial, partner 1 and partner 2, with US core valve pivotal trial with notion also, and staccato trial, and SIR-TAVI trial with also partner 3, and the prize 3 also trial. And today, one of our colleagues will present the partner. So I will just mention them by name. Partner 1 trial dealing with transcatheter versus surgical aortic valve replacement in high-risk patient, and analyzing the outcome of 699 patients were undergo SAVR or TAVI in Edward Sabine valve, and 30-day mortality for TAVI was 3.4, for SAVR 6, and for 1 year mortality rate was 24 for TAVI and 26 for SAVR with significant p-value. And for partner 2, it's dealing with transcatheter or surgical aortic valve replacement in intermediate patient. And this is in Edward valve to SAVR. The primary endpoint was all-cause mortality and disabling stroke at 2 years occurred in 2 years, 90% in TAVI and 21% in SAVA. However, when there is a resulting with satisfying with transfemoral approach, the primary endpoint occurred 16 in TAVI and 20 in SAVA, with p-value 0.05. Then this is a trans-catheter aortic valve replacement with the self-expanded prosthesis, core valve focal trial, mainly investigate transfemoral delivery balloon expanded and showing superiority of TAVI over SAVA for endpoint of all-cause mortality at 1 year with 14 to 19%. This effect had been disappeared after a follow-up year, especially in all-cause death. SAVA was 32 with 39 in TAVI. The rate of stroke was lower in TAVI, and surgical approach was associated with higher rate of major bleeding and kidney injury with atrial fibrillation. This is the notion Nordic aortic valve international trial, where enrolled 280 patients of age of 70s at least and assigned for TAVI with Medtronic core valve or SAVA. And more than 80% of patients were considered at low risk for surgery with STS 2.9 and TAVI 3%. So there is no significant difference in all-cause mortality. TAVI was 4 and SAVA 7, or stroke between two groups at 1 year follow-up. Similar results were observed at 2 years. SCATU trial, which is a prospective randomized trial of transapical transcatheter aortic valve implantation versus surgical aortic valve replacement in operable elderly patient with aortic stenosis. This is a small randomized trial, more than 80 patients age of patients, and terminated prematurely due to excessive incidence of primary endpoint of 30 days all-cause mortality, and compared to SAVA. Then after that, TAVI trial, surgical or transcatheter aortic valve replacement in intermediate risk factor, patient, intermediate risk. Total patient was 1,660 with intermediate risk, comparing TAVR to SAVR in 87 center. At 2 years, they show estimated incidence of primary endpoint was 12 in TAVI and 14 in SAVA. And surgery was associated with a higher rate of acute kidney injury, atrial fibrillation, and transfusion, with TAVI have higher rate of residual aortic regurgitation and need of pacemaker. In partner 3, in low-risk patient, 1,000 patients with low risk at 30-day mortality risk, TAVR to balloon expanded. Edward, there is a combination endpoint, death and disabling stroke at 1 year was 1 in TAVI and 2 in SAVA. Then lastly, 2 year Reprise 3 randomized clinical trial, 2 year outcome after transcatheter aortic valve replacement with mechanical versus self-expanded valve. This is 912 patients with high risk patient, symptomatic aortic stenosis, have been done from 2014 to 2015, randomized to receiving Lotus or core valve in 55 centers in North America and Europe and Australia. First 2 years result, first 2 year visit 2016, showing all-cause mortality rate and similar between Lotus and core valve, and disabling stroke functional class and valve migration favor Lotus, whereas The valve hemodynamic and thrombosis and the new pacemaker, it's more on core valve. For the insertion of percutaneous valve approach through the transfemoral approach, it should be done in a hybrid fluoroscopic impression room with the femoral artery and venous line introduced percutaneously, using closed device to at the end of procedure, or we can do it with the open technique and open the groin and expose the femoral artery and vein, which such decrease the vascular complication. Then venous pacing wire is inserted through the femoral vein to the right ventricle, through the jugular, sorry, to the right ventricle. Then two arterial wire inserted into the groin, one for pigtail catheter and the other for device sheath. Then we should heparinize, and HTT should be range between 250 to 350 seconds. And then once aortic valve is crossed with the straight wire, we should exchange the wire because that will injure the left ventricle with the extra stiff wire, and the balloon is then threaded over the guide wire and positioned across the aortic valve. Then during rapid pacing from 120 to 100, sorry, up to 180, and with the breathing or filtrating holding, then expand the valve at that point. Prior to insert the valve, loaded on the delivery balloon, confirm the orientation and position. Then thread over the stiff wire and load push into the sheath. The valve with the leading cone is then feed across the valve, to cross the valve, and then the cone is pushed further into the ventricle. Check the position by fluoroscopy, crossing the hinge point. Then patient breath is held and the heart pace up to 180. Then the balloon is inflated in position and then deflated. This is a transfemoral artery balloon expanded Edward valve, as we mentioned just before. The valve is positioned at the valve hinge point, approximately 62 to 70% into the aorta and 30 to 40% into the ventricle. And this is my reference. And Dr. Ahmed Arifi review in current evidence. You can, anybody, he can review it. And that's all. Thank you.
Thank you so much, Dr. Khalifa. Is there anyone having any comments, any question? You guys welcome to ask.
I just want to thank you for this excellent lecture. It's really helpful and summarizing all the updated evidence and the related information about the subject. Thank you.
Thank you, Mr.
If nobody asks, I will just say a few words here. It's a pleasure to know you, Khalifa, and you have a wonderful presentation which covered the subject very well. And I think we have, as a future cardiac surgeon, I think you all have to be aware that TAVI is here to stay. And I think it's another way of helping our patients in terms of securing a management for severe aortic stenosis at the moment. And I think you have described the different valves, you have described the different approaches, and at the same time, what I would have to say that we all have to be educating ourselves, and we have to put ourselves on the map for this structural heart intervention, and TAVI is one of them. Future mitral valve is another field. So I think it's a challenging to be part of the heart team. I know it's a lot of, it's not only here, worldwide, there's a lot of protection from cardiologists that this has to be just a cardiology field. But I think with some enthusiasm, I give you my experience in this field. I went and I trained and get certified in 2 valves, Edward and core valve, before I put myself on the map to be implanter. At the same time, you have to be humble and you have to work closely with the cardiologist, and we all have the same goal, because TAVI is require teamwork. And at the same time, it needs to build up a heart team in every center to be able to help our patients. In relation to TAVI, if we talk about as a technique, you mentioned the complication. I am very aware of the common complication which you should be aware of. First is a vascular complication. Vascular complication is related really to long-term hospital stay, morbidity, and mortality. The other thing is the difference in the paravalvular leak between the 2 valves. Medtronic, by definition, they have a higher paravalvular leak. And it's been shown that anything more than mild paravalvular leak is associated with long-term re-intervention rate, and at the same time, valve failure. The other issue, which is heart block. And on the other hand, Edward valve has a higher incidence of heart block because of the nature of balloon expanding valve. So each valve type has a specific patient characteristic where you could implant it for. The other point which I like you to be aware of is there is no one valve which fit all. There are certain patients who will benefit from core evolute valve, and there are certain patients who will benefit from Edward valve, which are the 2 most common currently used. So for example, if you have a patient who have a previous coronary artery bypass and you have a grafts in the ascending aorta, you don't want to put a valve which protruding into the ascending aorta, which is a core evolute valve. You rather put Edward valve because it doesn't protrude significantly beyond the annulus. It's only 14 millimeter above the annulus. This is the profile of the valve. So this is some points I like you to be aware of. I know it's a challenge. It's to be part of these programs, but as a young surgeon, I encourage you all to find a way to be engaged in a fellowship or any form of training programs to be able to get educated about these and be part of this program for the future. Thank you.
Thank you, Dr. Ahmed, for your thoughts.
Well, thank you, Dr. Arif, for your input. Much appreciated. And thanks, Dr. Khalifa, for your lecture. Amazing lecture. So we're going to have 10 minutes break. Then we will talk about the partner trial. It will be presented by Dr. Sultan. Okay.
If you allow me, I have a heart transplant meeting, so I might not be able to join you for the last trial.
Thank you so much. Thank you.
Thank you.
دكتور سلطان.
مرحبا، هلا.
هلا وسهلا، كيف حالك؟
الحمد لله بخير، الله يسلمك.
You ready to go?
Yes, I am.
Okay.
Okay. I will share my screen. Can you see my slides? Are my slides clear?
Yeah.
Yeah, okay. So, Assalamu alaikum everyone. My name is Sultan Askar, R1 cardiac surgery resident at Prince Sultan Cardiac Center Al Hassa. And today I'll be presenting the Journal Club about the partner trial. The partner trial was actually, the partner 1 trial was included 2 cohorts of patients, partner B and partner A, and I'll talk about both of them. So as a brief introduction, aortic stenosis is an insidious disease. Usually after the appearance of symptoms, there is a rapid progression, and if left untreated, there is a high death rate, about 50% in 2 years after symptoms begin to appear. So surgical replacement prior to the era of TAVI was actually improved survival and reduced symptoms. However, up to 30% of patients at that time did not or could not undergo cardiac surgery, either due to advanced age, comorbidities, or LV dysfunction. So the transcatheter aortic implantation for patients with severe aortic stenosis who cannot undergo surgery saw patients with severe aortic stenosis who are not candidate for surgery and compared TAVI to standard medical therapy, which included in that study balloon aortic valvuloplasty. And the outcome that was tested was the rate of survival at 1 year. So the conflict of interest in the study, the authors attest that some of the authors received consulting fees from Edwards Life Sciences and stock options, and other than that, there are no conflicts of interest. The design of this study was actually randomized. It was a randomized trial, parallel, prospective, and multi-center with an active treatment protocol. It took place from May 11th, 2007 until March 16th, 2009. The number of enrolled patients was 358 with an overall STS risk of 11.6% plus minus 6%. The inclusion criteria was severe aortic stenosis, which was defined by any of the following: aortic valve area of less than 0.8 centimeters squared, or an AVA index of less than 0.5 centimeters squared per meter squared, a mean aortic valve gradient of 40 millimeters of mercury or more, a peak aortic jet velocity of 4 meters per second or more, or an NYHA functional class of 2 or more. The patients had to be poor surgical candidates by any of the following criteria, which had to be confirmed by at least 2 surgeons. These criteria included an STS score of 10% or more, or a coexisting conditions with 15% or more, or 30-day postoperative risk of death, or coexisting conditions with a 50% or more 30-day postoperative risk of death or serious irreversible condition. The exclusion criteria for this study included bicuspid or non-calcified valve, acute myocardial infarction, substantial coronary artery disease, severe peripheral vascular disease, a left ventricular ejection fraction of 20% or less, or a diameter of the aortic annulus of either less than 18 millimeters or more than 25 millimeters, severe mitral or aortic regurgitation, and TIA or ischemic stroke, or TIA or stroke within the past 6 months, and severe renal insufficiency. So initially 3,105 patients were screened. Out of those, 358 were selected for this cohort of patients. The endpoints, the primary endpoints was all-cause mortality at 1 year, and the hierarchical composite of all-cause mortality or the time of first occurrence or repeat hospitalization due to valve-related or clinical deterioration. The secondary endpoints included cardiovascular mortality at 1 year, repeat hospitalization after the procedure, either due to valve-related or clinical deterioration, NYHA class at 1 year, the 6-minute walk distance at 1 year, the valve performance, which was assessed by echo, and not mentioned here, also vascular complications. So the baseline characteristics, as we can see here, are fairly similar between the two groups, the TAVI and the standard therapy group. There were 179 patients in the TAVI and 179 in the standard therapy group. The mean age was 83.1 in both, 83 in both groups. The male sex contributed to 45% in the TAVI group and 46.9% in the standard group. Of note, however, is that, as you can see here, the Euro score was statistically higher in the standard therapy as compared to the TAVI group, which, according to some experts, may have led to worse outcomes in the standard therapy as compared to the TAVI group. Otherwise, there was no significant difference between the two groups. Baseline characteristics were fairly similar. This is the valve that was used, the Edward Sapien valve, the tri-leaflet valve. It was, as was explained by our colleague in the previous lecture, and how on the way it was implanted. The outcomes at 30 days and at 1 year were as follows. Death from any cause at 30 days was 5% in the TAVI group versus 2.8% in the standard therapy group. However, at 1 year, we can see that the TAVI, the death rate from any cause between the TAVI and the standard therapy, there was a significant difference, 30.7% in the TAVI group versus 49.7% in the standard therapy. The death rate from cardiovascular causes, it was not significant at the first 30 days. It was 4.5% versus 1.7% in the standard therapy group versus 19.6% at 1 year in the TAVI group versus 41.9% with a p-value of less than 0.001. Stroke or TIA was significant. Neurologic events were more prevalent or more significant in the TAVI group, both at 30 days and at 1 year. 6.7 versus 1.7% at 30 days with a p-value of 0.03, and at 1 year 10.6% versus 4.5 in the standard therapy group with a p-value of 0.04. However, when put in a composite endpoint, death from any cause or major stroke, we can see that there was no significant difference in 30 days. It was only 8.4% of the TAVI versus 3.9 in the standard therapy with a p-value of 0.12. However, at 1 year, it was 33% of the TAVI group versus 50.3% in the standard therapy with a p-value of 0.001, which is quite significant. Vascular complications were, of course, more prevalent and significant in the TAVI group, both at 30 days and at 1 year. Other than that, yes. So, as I said before, the rate of death was 5% versus 2.8% of the standard therapy group. At the 1 year follow-up, there was that was found that 30.7% in the TAVI group had died as compared to 50.7% in the standard therapy. The rate of death, again, from the cardiovascular causes was 20.5 versus 44.6% in the standard therapy group. The major stroke, as we said before, it was observed more in the TAVI as compared with the standard therapy group. And here we can see in the Kaplan-Meier, the death from any cause at 1 year, it was more significant in the standard therapy group, 50.7 versus 30.7 here. And death from cardiovascular causes was more significant also in the standard therapy as compared to TAVI group. And death from any cause or repeat hospitalization, again, more significant in the standard therapy as compared to the TAVI. And composite death from any cause or major stroke, again, was more significant in the standard therapy group as compared to the TAVI. A subgroup analysis was carried out to see if there is any interaction between these specific subgroups, which included age, sex, BMI, STS score, ejection fraction, pulmonary hypertension, presence of severe mitral regurgitation, COPD, history of prior CABG or PCI or peripheral vascular disease. However, this subgroup analysis found no significant interaction between any of these subgroups and the trial. The symptom status at 30 days and 6 months at 1 year, actually, the symptoms were significantly reduced in the TAVI group as compared to the standard therapy with a p-value of less than 0.001. At 1 year, 74.8% of patients who had undergone TAVI, as compared to 42%, were asymptomatic or had mild symptoms, NYHA class 1 or 2. As we can see here on the chart, this is the baseline. At 30 days, there was a significant reduction in symptoms in the TAVI group as compared to the standard therapy. And again, at 1 year, you can see that there was a significant reduction in the symptoms of patients in the TAVI group. Echo assessment actually found that mean aortic valve area increased from 0.6 plus minus 0.2 centimeters squared at baseline to 1.5 plus minus 0.5 centimeters at 30 days, which was quite significant. And the gradient was found to be decreased from 44.5 plus minus 15.7 millimeters of mercury to 11.1 plus minus 6 millimeters of mercury. And at 1 year, this reduction in gradient and the increase in the valve area was maintained. However, it was found that moderate or severe paravalvular aortic regurgitation was present in 11.8% of patients in the TAVI at 30 days and in 10.5% at 1 year. However, this aortic paravalvular regurgitation was not increased at 1 year of assessment, so it was maintained. So the incidence of transvalvular aortic regurgitation was 1.3% at 30 days and 4.2% at 1 year among patients in the TAVI group, as compared to 16.9% and 15.2% in the standard therapy group. This table here shows the echocardiographic findings in the study population. As we can see here, paravalvular aortic regurgitation. It was found that 68% at 30 days had mild trace or mild aortic regurgitation. However, at 1 year, it was 59%. And moderate to severe, it was found, as mentioned before, 12% of patients had moderate to severe aortic paravalvular regurgitation, and at 1 year, it was 11%. So this study found that standard medical therapy did not alter the natural history of aortic regurgitation, as evidenced by the rate of death, which was 50.7% in the standard therapy, and the rate of death from cardiovascular causes. So transfemoral TAVI was found to be superior to standard therapy, markedly reducing symptoms and the rate of hospitalization. The rate of death at 30 days among patients who underwent TAVI was not significant at first, in the first 30 days. However, at 1 year, it was found to be quite significant. So TAVI, as we said before, it was associated with a significant reduction in symptoms. However, there were more neurologic events, including strokes or major strokes, and more vascular complications and bleeding in the TAVI group as compared to the standard therapy. Echo findings and indicated that hemodynamic performance of the valves was excellent at 1 year. However, there usually was a paravalvular aortic regurgitation, which was usually, in most cases, trace or mild. So on conclusion, on the basis of this trial, they concluded in the study that TAVI should be the new standard of care in patients with aortic stenosis who are not suitable candidates for surgery. The limitations of the study included that up to 83% of patients had actually undergone balloon aortic valvuloplasty, which had the level 3 at the time. It was quite a harmful procedure at the time in the guidelines, and that may have contributed to the worsening of outcomes in the standard therapy group as compared to the TAVI. And this study also excluded patients with coronary artery disease and severe peripheral vascular disease, and those patients whose left ventricular ejection fraction is less than 20%, who could have benefited from this type of procedure. Now we finished with cohort B. I'm going to talk about cohort A, which was the transcatheter valve replacement in high-risk patients. The patients in question were patients with severe aortic stenosis who were considered to be high risk for surgery, operable but high risk. And the comparison was the intention was to compare TAVI to surgical AVR. And the primary hypothesis of this study was that transcatheter replacement is not inferior to surgical replacement. Again, this study was prospective, multi-center, open label, randomized and parallel. It took place from 11th of May 2007 to August 28, 2009. The number of enrolled patients was 699 patients. The inclusion criteria was similar to the previous study. The high-risk operative complications were defined as either coexisting conditions with 15% or more 30-day post-operative risk of death, or an STS score of 10 or more. The exclusion criteria were also similar: bicuspid, non-calcified valve, coronary artery disease, left ventricular ejection fraction less than 20, annulus less than 18 or more than 25, severe aortic or mitral regurgitation, recent neurologic events, or severe renal insufficiency. So the primary endpoint of this study was all-cause mortality at 1 year. The secondary endpoints were death from cardiovascular causes, NYHA functional class, repeat hospitalization due to valve-related or procedure-related problems, MI, stroke, acute kidney injury, vascular complications, bleeding, the 6-minute walk distance, valve performance as assessed by echo, new pacemakers, and new onset of atrial fibrillation. The baseline characteristics, again, were fairly similar between the two groups. The mean age was 83.6 in the transcatheter replacement versus 84.5 in the surgical replacement. Males constituted 57.8% in the transcatheter versus 56.7 in the surgical replacement group. Other than that, the baseline characteristics were fairly similar. So the 30-day and 1 year outcomes, as can be seen here, at 30 days, there was no significant difference in death from any cause in both the transcatheter or the surgical group. It was only 3.4% in the transcatheter group versus 6.5% in the surgical arm, with a p-value of 0.07. And again, at 1 year, there was no significant difference. 24.2 in the transcatheter versus 26.8 in the surgical arm, with a p-value of 0.44. Death from cardiac causes was 3.2% in the TAVI group versus 3% in the surgical group, with a p-value of 0.9. And after 1 year, it was 14% in 14.3% of the TAVI versus 13% in the surgical replacement, with a p-value of 0.63. However, it was noticed again that stroke or transient ischemic attacks were more prevalent in the TAVI group, with 5.5% in the first 30 days in the TAVI group versus 2.4 in the surgical replacement group, with a p-value of 0.04. And at 1 year, it was found that 8.3% had strokes or TIAs in the TAVI group versus 4.3 only in the surgical replacement group, again with a p-value of 0.04. However, when put in a composite of death from any cause or major stroke, there was no significant finding. At 30 days, 6.9 in the TAVI versus 8.2 in the surgical, with a p-value of 0.52 versus 26.5 at 1 year in the TAVI group versus 28 in the surgery group with a p-value of 0.06. Vascular complications were more prevalent again in the TAVI arm, 17% versus 3.8% in the first 30 days, with a p-value of 0.01. And at 1 year, at 18% versus 4.8 in the surgical group, with a p-value of less than 0.001. Major bleeding, however, was found more prevalent in the surgical arm of the group. At 30 days, it was only 9.3% in the TAVI versus 19.5% in the surgery group, with a p-value of less than 0.001. And at 1 year, the same, 14.7% in the TAVI versus 25.7% in the surgical group. New onset atrial fibrillation was actually, there was no significant difference, but at 1 year, but at 30 days, it was found that new onset atrial fibrillation was more prevalent in the surgery group, 16% versus 8.6% with a p-value of 0.006. So this curve here shows the death rate from any cause at 30 days, as we said, at 1 year, sorry, this is at 1 year. The 24.2% of the TAVI group versus 26.8 with a p-value of 0.62. So there was no significant difference. And according to the study, this difference of percentage between the surgery and the transcatheter met the non-inferiority margin of this study So they were able to determine that TAVI was non-inferior to surgery in high-risk patients. In this curve, we can see the death from any cause in the transfemoral cohort, because patients were either randomized to either transfemoral or transapical. In the transfemoral cohort, 22.2% died at 12 months versus 26.4% in the surgery group, and at the transapical group, 29% died at 12 months versus 27.9% in the surgery group. And death from any cause or major stroke, there was no significant difference between transcatheter or surgery at 1 year. A subgroup analysis of the same subgroup of patients was done to see if there is any significant interaction between these subgroups and the outcome of the study, and it found that TAVI was more favorable in females, as you can see here, and in patients with no history of prior CABG. It was found that TAVI in those patients did better in this trial. Regarding the symptom status at 30 days, you can see that there was a significant reduction in symptoms in both groups. However, the TAVR group did better than the surgical group in both NYHA functional class and the 6-minute walk test. And at 1 year, however, you can see that both groups were quite similar in their functional class and their 6-minute walk test. The echo assessment found that AV gradient was significantly better for both groups of patients, both at 30 days and at 1 year. However, at 1 year, the TAVI group was slightly superior to surgical group in regards to the mean aortic valve gradient. It was found to be 10.2 plus minus 4.3 millimeters of mercury in the TAVI versus 11.5 plus minus 5.4 millimeters of mercury in the surgical group with a p-value of 0.008. And the mean valve area was actually also a little bit better in the TAVI group with at 1 year, 1.59 plus minus 0.48 centimeters versus 1.4 and plus minus 0.47 centimeters squared with a p-value of 0.002. However, as we said, that moderate, severe or severe paravalvular regurgitation was found more in the transcatheter group than the surgical group at 30 days and at 1 year. At 30 days, it was found that 12.2% had moderate to severe paravalvular leaks versus 0.9% in the surgery group, and at 1 year, 6.8% versus 1.9%, with a p-value of less than 0.001, so which was quite significant. This table here shows the echo findings of paravalvular leaks. Again, you can see that in the TAVR group, in the TAVR group, trace to mild paravalvular regurgitation was found in 65% at 30 days, and at 1 year it was 60.4%, compared to 25.3% in the surgical group versus 20.1% in the after 1 year. Transvalvular aortic regurgitation was found in the TAVR group was found at 63.6% at 30 days, and at 1 year it was found in 62.7% after 1 year. In the surgery group, it was found that 43% had mild to trace aortic regurgitation, transvalvular aortic regurgitation, and at 1 year this was 44.7%. However, in the moderate to severe, aortic regurgitation was found only in 1% of patients with TAVI at 30 days and 0.9% at 1 year. In the surgery group, there were 0.9% of patients with transvalvular aortic regurgitation at 30 days. However, at 1 year, there were no patients with moderate to severe aortic regurgitation. So TAVI was found to be non-inferior to SAVR in the study with respect to rates of death from any cause at 1 year. Clinical benefits of TAVI included significantly shorter hospital stays in the ICU or hospital stay in general. In addition, the NYHA class and the 6-minute walk test were strikingly improved for both groups at 1 year. However, at 30 days, the TAVI group did better. The higher rates of strokes were actually were observed more in the TAVI group, and TAVI was associated with more vascular complications However, surgery was associated with more major bleeding and new onset atrial fibrillation. So they concluded in the study that surgical aortic valve replacement and balloon expandable transcatheter replacement were associated with similar mortality at 30 days and at 1 year, and produced similar improvements in cardiac symptoms. So transcatheter replacement, they concluded, is an alternative to surgical replacement in a well-chosen high-risk subgroup of patients with aortic stenosis. Another trial, which that was published in 2015, which was the 5-year outcomes of TAVI for high-risk patients with aortic stenosis, found that all-cause mortality between both groups of patients was not significant. It was 67.8% in the TAVI versus 62.4% in the surgery group, with a p-value of 0.76. And repeat hospitalization also, there were no significant differences, 42.3% in the TAVI versus 34.2% with a p-value of 0.17. And strokes were also similar, so there was no significant difference between the TAVI and the surgery, 15.9% the TAVI versus 14.7% in the surgery group. And echocardiography demonstrated that valve gradients and area was similar between the two arms at 5 years. So they concluded in that study as well that TAVI should become the new mode of treatment for patients who are high risk for surgery. These are my references. Thank you very much for listening, and if you have any questions.
Well, thank you, Sultan, for your presentation, but are you going to talk about the partner 2 and partner 3?
To be honest, I didn't. Well, I didn't know. I thought I was only going to be talking about partner 1. That's the only thing I prepared, to be honest.
Oh, it's okay, no problem. So, partner 2, up to my knowledge, that they talked about the TAVI group. TAVI versus SAVR in intermediate risk patients.
Yes.
And the partner 3, where they compared with a low risk patient.
Yes.
Right?
Yes.
Okay.
And in both trials, they found no significant difference between.
The main result of partner 2 that there was a low profile. It was non-inferior. TAVI was non-inferior to surgery.
Exactly.
With respect of outcomes of after 2 years.
Yes.
And the incidence of paravalvular aortic regurg was higher after the TAVR than after the surgery. Same with partner 1.
Yes.
There was also, up to my knowledge, several benefits with regards to secondary endpoint, where associated with TAVR group, including bleeding, aortic, acute kidney injury, and AF.
Yes.
As well as short stay at hospital.
Yes.
So the outcomes after transthoracic TAVR was similar with or worsening even than the surgical or the SAVR group.
Yes.
This is partner 2.
Yes.
And the conclusion was intermediate risk patients with a severe aortic stenosis, the surgical and and the SAVR and the TAVI were similar with respect of primary endpoints. And the partner 3, where they compared TAVI and SAVR in a low-risk patient, I think main findings was TAVR performed by mean or of transfemoral. They compared the TAVI, they focused on the transfemoral group. They excluded the transapical or transthoracic TAVI.
Yes.
The outcomes or the conclusion, I think that patient with severe aortic stenosis and low risk with surgery, the rate of composite death and stroke rehospitalization was significantly low on TAVR than the surgical aortic replacement. What you presented was really good presentation, but what is important to us is partner 2 and 3. But thank you anyway. It was a great presentation.
Thank you very much. I apologize. I thought that since when I saw the topic in the file, I thought there was only partner 1 because it didn't specify whether they want to talk all the partner trials.
Yeah, it's okay. It's okay. No problem. Thank you so much. Is there any question from the audience? Any input? Any suggestion? Okay. So I think we finished with our academic activity today. Thanks for the presenters, Dr. Zainab, Dr. Khalifa, and Dr. Sultan for today's activity. And thank you all. Have a great weekend.